Episode 13, a 19-year-old competitive collegiate wrestler presented to a sports cardiology clinic after an abnormal echocardiogram. He was incidentally diagnosed with a bicuspid aortic valve and aortic dilation after volunteering as a practice patient for sonographer training. This young athlete had no cardiovascular symptoms, no dizziness, syncope, no shortness of breath, palpitations, or chest pain. He reported occasional alcohol intake. He denied the use of tobacco products, recreational drugs, or performance-enhancing drugs. He had no family history of congenital heart disease or aortic pathology. At the time of evaluation, his parents were alive without any cardiac conditions. He was currently engaged in moderate to high-intensity isometric exercise, including weightlifting, with at least 4 times per week. His physical exam was reassuring, with a blood pressure of 102/72, a heart rate of 60, and he had normal limb lengths, normal uvula, normal skin findings, and normal joint mobility. Past medical history was significant for acute appendicitis with an appendectomy performed as a child. The differential diagnosis, as outlined by the authors, included genetically mediated vasculopathy like Marfan's syndrome or Ehlers-Danlos syndrome, congenital heart disease, aortitis, which could be either inflammatory, infectious, and degenerative aortopathy. The clinical evaluation included a transthoracic echocardiogram, which demonstrated a left ventricular ejection fraction of 66%. A bicuspid aortic valve with fusion of the right and left coronary cusps, mild aortic regurgitation, and mild aortic stenosis with mild dilation of the ascending aorta measuring 35 millimeters. Exercise treadmill stress testing showed excellent exercise capacity at 17 METs. Peak blood pressure was 116/76. There were no anginal symptoms and no electrocardiographic evidence of ischemia. Magnetic resonance angiography of the chest confirmed mild enlargement of the ascending aorta of 35 millimeters and the descending thoracic aorta measured 20 millimeters. I'd like to recognize the authors, Drs. Chhana, Rymer, and Vidula et al., with their case report of a collegiate wrestler with a bicuspid aortic valve published in the Journal of the American College of Cardiology in 2022. I'm Scott Hull, a primary care sports medicine physician at the University of Utah. I'm reviewing case studies in preparation for my sports medicine certification exam in 2026 and hope you'll join me on the journey. This podcast is for educational purposes only. Outcome. At the time of diagnosis, our wrestler did not meet criteria for surgical intervention for the aortic valve or aortic pathology. According to American College of Cardiology guidelines, athletes with more than mildly dilated aortas are cautioned against participation in contact sports with significant bodily collision risk, and wrestling would certainly be classified as a high-impact sport. The theoretical concerns include aortic dissection from deceleration injuries and accelerated aortic dilation from marked blood pressure increases that occur during heavy isometric exercise and Valsalva maneuvers. The authors noted that data in this field are limited, and there's some debate about the actual risk of adverse events in athletes with mild aortic dilation. I'd like to quote the authors as they work through this process. A patient-centric discussion, including using a shared decision-making model approach, was conducted. The goals of this conversation were to discuss the risks and benefits of restricting sports participation, given the unknown impact on the clinical progression of disease. Considerations included the possible resultant undesirable side effects of loss of athlete identity and decline in mental health from restriction of sports participation versus continued participation, with the risk of disease progression or significant cardiac event, such as aortic dissection. After this conversation, the patient elected to continue wrestling competitively with plans for frequent interval monitoring of symptoms and serial imaging for disease progression. He underwent echocardiography and magnetic resonance angiography 6 months later, which demonstrated stable aortic size. He continues to wrestle competitively at the collegiate level with serial monitoring and imaging with minimal interval disease progression. In this case, a careful consideration of the patient's values and preferences was balanced with the risk of cardiovascular morbidity and mortality. Key takeaways, and I've got two from the authors. Number one, athletes with a bicuspid aortic valve should be evaluated for aortic regurgitation and aortic stenosis at least annually, and the decision to participate in sports should involve risk stratification based on the severity of valvular disease and associated aortic pathology according to current American Heart Association and American College of Cardiology guidelines for athletes with cardiovascular abnormalities. Recent cardiology guidelines have reinforced the importance of shared decision-making for all patients, and this is particularly important for patients who are athletes. Involving the patient and other stakeholders in the decision-making process can aid in the understanding of risk and probability of adverse events, thus enabling athletes to make informed decisions. This is one of my takeaways. Guidelines can provide a framework but cannot account for every different individual situation. Involving the athlete and other stakeholders in understanding risk enables informed decisions that respect patient autonomy. I really like this case study. I thought the authors did an excellent job, and it gave me some very clear guidance on how to manage aortic pathology and bicuspid aortic valves, and I've got a couple of practice questions for you. Question 1. Which of the activities should be avoided by patients with significant aortic stenosis regardless of severity? Answer. Intense isometric exercises, heavy weightlifting, activities requiring the Valsalva maneuver, burst exertion, and collision sports. Both the American College of Cardiology and the American Heart Association recommend that individuals with significant aortic disease avoid these high-risk activities. Patients with moderate to severe aortic stenosis should specifically avoid competitive sports that involve high dynamic and static muscular demands. However, for patients with adequately controlled blood pressure, 30 to 60 minutes of mild to moderate intensity aerobic activity at least 3 to 4 days per week is reasonable. Question 2. A 20-year-old tennis player with a bicuspid aortic valve but no stenosis asks about monitoring recommendations. What is the recommendation for appropriate surveillance? The answer. Yearly physical examinations for detection of new onset heart murmurs. Athletes with bicuspid aortic valve without stenosis require annual physical examinations to detect the development of aortic stenosis. It is important to assess the size and morphology of the ascending aorta to exclude concomitant aortic pathology, as bicuspid aortic valve is associated with aortic pathology. First-degree relatives should also be screened, as bicuspid aortic valves can have autosomal dominant inheritance with variable penetrance. No sports restrictions are necessary in the absence of stenosis or aortic dilation. Thank you.